Thank you, Dr. Murray, for that introduction and the invitation on behalf of IARS, in addition to SAGA, which is a very small but passionate group as compared to, kind of in size-wise, compared to SOAP and to SPA. And if anyone has any interest, it's certainly an organization I recommend getting involved with. One of the things to think about, and I reflect on this as I recently was attending a talk on damage control resuscitation by a trauma surgeon who mentioned that kind of he went into trauma surgery with the idea of kind of penetrating injury, gunshots, stab wounds and things, and what he has essentially become is a geriatrician because the majority of the patients which fill his particular trauma ICU are patients who have fallen and have had injuries from falls, as Dr. Murray pointed out. So with that, I will move forward. I have no disclosures. So here are the intended learning outcomes for today. We'll talk a bit about the demographics related to geriatric trauma and then segue that into the unique physiology of geriatric patients as there is significant physiologic change as one ages. We're going to talk about kind of a geriatric specific means of triage and assessment, and then more specifically discuss management of hip fractures, which is probably one of the more widely studied and intervened upon injuries that geriatric trauma patients present with. And I'm going to close the talk because I would feel remiss without discussing the concept of clinical momentum and how that can impact your management of geriatric trauma patients. So we'll start off with the demographics. As you all know, the population is aging, and there is predicted to be, based on the 2010 census, nearly a doubling, or actually over a doubling, of the population of folks age over 65, and a tripling of those over age 85. And that's really impactful because you also are starting to have this shift in terms of the population of traumatic injury from people over age 65, going from less than a quarter of trauma patients presenting to about a third of trauma patients presenting now. And you'll notice that there's also an interesting demographic shift in terms of females start to outnumber males in terms of their presentation with traumatic injury. And why this is really concerning is because at that kind of point of 65, you have this inflection point where your case fatality rate goes up significantly. And there's some data that says that every year over age 65, you can increase your mortality rate by almost 7% just by increasing your age. And to me, that is really disconcerting. It's also a huge kind of concern in terms of healthcare expenditure, because this population also encompasses about a third of the healthcare expenditure in terms of traumatic injury. Mechanism of injury, as Dr. Murray pointed out, it's falls, primarily falls. You also do get a good percentage of motor vehicle accidents, but the primary mechanism of injury that you're going to have coming in and you're going to deal with are falls, and especially falls from standing or falls from a level ground, which leads oftentimes to under triage of these patients, which in my estimation is one of the big characteristics as to why you have that issue with fatality. Top 10 complications, I put this up here because just because you get the patient through kind of the management of that specific traumatic injury, they're also at a significant risk for things such as pneumonia, urinary tract infections. The things that is left off of here that is probably the number one complication, or it is the number one complication, is delirium. And that is such an impactful diagnosis for these patients as they come in, and a huge contributor to morbidity and mortality. So the big question when you start to think about geriatric trauma patients is when it comes to outcomes, so you have that inflection point at age 65, is it the age of the trauma patient that matters the most? Is it the pre-existing comorbidities that they're presenting with, or is it a combination of both? And that's one of the things that I hope to kind of convince you of, or the answer that I hope to convince you of as we go through. An important point as you start to think about it is that the physiologic changes associated with aging aren't pathologic, but one's ability to respond to stressful stimuli, so to the ability to respond to a traumatic situation, also known as functional reserve or your physical reserve, becomes compromised. So let's talk about some specific physiologic considerations for geriatric patients, and this is going to impact how you assess them. So as you can see, geriatric patients and just aging patients in general have significant changes in all of the kind of body systems as you go through. From a CNS perspective, you get a decrease in brain mass, you get reduction in your cerebral blood flow, and you also get reduction in neurotransmitter activity, all which can be impactful in terms of your management of a trauma patient, but it's also really impactful in terms of this is often the cause that people are coming in with the trauma. So they lose that gait stability or the proprioception, and they take that fall from standing, which leads them into the intensive care unit or into your trauma bay. Cardiovascularly, there's a huge incidence of diastolic dysfunction and diastolic heart failure, so you have to be really mindful of that, as many of the ATLS protocols will often emphasize the role of aggressive resuscitation, and oftentimes in this patient population, that can actually be catastrophic for them due to their inability to tolerate that kind of rate of volume. They're also less responsive to catecholamines, which is really important when you're thinking about triaging these patients, in addition to kind of being more prone to autonomic kind of dysrhythmias, et cetera, because some of their tissues are replaced by fat or scar tissue. When you think from a respiratory standpoint, there's a loss of pharyngeal reflexes, in addition to a kind of a loosening of the lower esophageal sphincter, which is really, really important because it leads to reflux. And these are patients that you may consider establishing a secure airway a little bit more quickly. You get an increased closing capacity, which is going to predispose them to kind of more of a risk of hypoxia, in addition to things like decrease in chest wall compliance, a tendency towards rib fractures, et cetera. From a renal perspective, you get a loss of renal tubular mass and a decrease in your renal blood flow, and these patients oftentimes will present with completely normal creatinines throughout their hospital stays, will have normal creatinines, but it is certainly not a sign or an element that signifies that they have normal renal function. They just have reduced muscle mass. Pharmacologically, so along the same level, you get a decrease in your level of proteins and protein binding. So you have to be really mindful of your drug dosing in this patient population, as even small doses or kind of traditional doses can have a big impact in terms of the physiologic manifestations that they encounter. So let's talk about triage. So there have been some centers that have actually, and this is a big economic investment, created geriatric-specific EDs. And it's mainly level 2 centers that have these. There are some level 1 centers that have these. But it's something that's worth considering. It's certainly an expensive endeavor, but based on the fact of kind of that increasing morbidity and mortality with every year over age 65, it's something that might be beneficial. So why should we triage these patients specially? What we do know is that the routine mechanism for triage, and this is triage out in the field, so patients presenting from their home or a business into the hospital, that it's usually mechanism of injury and vital signs. And what we know is that approach is completely insufficient for geriatric patients, and that despite the fact that a lot of patients will have high injury severity scores, that they'll often have normal vital signs on presentation. And that's due to their pre-existing comorbidities. So they might be hypertensive at baseline, they might be on beta blockers, et cetera, and not be able to manifest those abnormal vital signs. There was a study, a small study, that showed that if you add a threshold of 70 years, just that criteria, age criteria, as an indicator for trauma team activation or triage to a higher level trauma center, that it actually reduced your morbidity and mortality in terms of improving outcomes, and was also cost effective. So the rate of over triage was actually pretty low. There's some data that shows that patients that go to trauma centers that care for larger volumes of geriatric patients tend to do better. So they're more likely to have lower rates of in-hospital mortality and major complications in terms of the management of that, or in terms of the management of their traumatic injuries. Interestingly, those centers that care for large volumes of younger trauma patients tend to have higher rates of major complications for geriatric trauma patients. And I think this goes to the fact that the approach to the geriatric trauma patient is the same as the approach to a younger trauma patient in their 20s or 30s. And that, frankly, is just insufficient, and you're going to kind of result in major morbidity and mortality. In terms of assessment, so as my colleagues have already pointed out, ATLS is so important when it comes to kind of our daily functioning as anesthesiologists, especially in the management of trauma patients. And this is just kind of the standard ATLS survey. And what I'm going to propose to you is a modification of this ATLS survey as it goes through with specific indications or assessments for geriatric patients. So in management of the airway, there's often macroglossia. You have to take into account that many patients are coming in and they're going to be edentulous and more prone to obstruction. I've already mentioned the lower esophageal sphincter tone, which gives you that higher risk of aspiration. And you also have to consider those arthritic processes that decrease your neck mobility and lead to the potential for difficult airway or pre-existing cervical spine injuries coming in. And even though it's just a fall from standing, there can still be that cervical spine injury. Breathing, so chest wall rigidity, you have decreased compliance, you have those higher closing volumes, which are going to lead to those increased VQ mismatch. So attention to kind of the ability to take breaths and oxygenate, and using supplemental oxygenation or endotracheal intubation if required. Circulation, we've already talked about diastolic dysfunction and kind of really close attention to that as you're going through your assessment and your resuscitation for these patients. And the fact that they're going to be end diastolic volume dependent in stress, and you want to make sure that you're providing kind of the ability to do so. And also remembering that these patients are often on beta blockers and anticoagulants, which is a huge issue in managing these patients, especially when you start to think about deficits and the fact that the walls of the bridging vein of the dura are going to be prone to tearing, leading to subdural hemorrhage. And if you think back to kind of the fact that brain mass is decreased, just because a patient hasn't necessarily manifested mental status changes for you yet does not necessarily mean that they don't have a brain bleed. It just means that they might not have enough blood in their brain yet to manifest those mental status changes. This is going back a little bit, but when you think of kind of the neuro effects and the neuro assessment of these patients, oftentimes confusion and mental status changes are just attributed to delirium or to dementia and not necessarily to traumatic injury. Exposure, so skin and thermal regulation become incredibly impaired. Skin breakdown's very common. It's not mentioned here specifically, but you want to have careful attention to pressure points and be sure to make sure you're having these patients moved and turned, as decubitus ulcers can be deadly. Hypothermia is a big issue, and you want to make sure you use things like bear huggers, increase room warming. Frankly, everyone in the room should be sweating in order to maintain the body temperature of these patients. I'm going to propose that there's an F added to the the ATLS algorithm, and here's my patient example to explain why. So you have an 80-year-old female who is admitted to the intensive care unit after a mechanical fall down 4 stairs. Her trauma burden includes the left subdural, left 3 through 8 rib fractures, and a hip fracture. So patient 1, who's in trauma bay 1, has hypertension, hyperlipidemia, CAD. She's had a CABG, she has COPD, is on nocturnal HOMO2, and has also diabetes. She lives with her daughter, and she requires significant help with shopping, housework, and meals, but is otherwise independent. The patient in the next trauma bay, who has the same exact mechanism of injury, same exact injuries, just has hypertension, hyperlipidemia. She lives independently, and she has no assistance with her ADLs. So clearly, same burden, same age, but clearly 2 very different patients in terms of how you're going to manage them. So how do you differentiate these? And the way you differentiate these, and this is the current buzzword within kind of geriatric anesthesia and geriatric trauma, is kind of assessment of the concept of frailty. And it's essentially a phenotype of multi-system impairment with expanding vulnerability, which is associated with a higher risk of adverse health outcomes that are not entirely explained by aging. So it's not entirely just the aging process that attributes to the increased morbidity and mortality, but rather there's some other component there. So it is a predictor of morbidity and mortality in terms of it's an independent predictor of adverse disposition to a skilled nursing facility, or independent predictor of adverse outcomes, so death or other kind of complications while in the hospital. One of the problems with frailty is there's no agreement on how to measure it. So I'll show you a few different papers here, and they all propose very different mechanisms. Some of the frailty indices include just 3 or 4 kind of measures, whereas other frailty indices go up and they include 40 different measures. And clearly this is a big problem because you have to have an agreement on how to measure a specific function. That way you can provide really good data to the patient's family and to the patient as an assessment, because clearly if you identify that a patient is very frail coming into the hospital, and the data supports this, that the outcomes are likely going to be pretty poor. So let's talk about management and specifically orthogeriatrics. And essentially, there was an all-cause mortality increase in American and European patients after they suffered hip fractures, and it remained elevated for up to 4 years. There's some data that says that mortality is about 25% at 1 year post-traumatic injury in age 65 plus, and a lot of that is due to hip fracture. So as a means of trying to improve care coordination for these patients who are suffering from this type of trauma, with a particular focus on hip fractures, the concept of orthogeriatrics was developed. So even with integration of a orthogeriatrics team, most of the geriatric patients still have some type of complication, including delirium, anemia, UTIs, and pneumonia. And the biggest predictor of complication is pre-injury functional status. So if from a functional standpoint you are very frail coming into the hospital before you've had your injury, the likelihood that you recover from that injury is pretty small. If from a pre-injury standpoint you are not frail and actually independent, there's still a very significant chance, almost 3/4 chance, that you're gonna not return to that same baseline level of function. And that's scary for patients to hear, and it's really important though for their family to hear that. Surgical management in terms of should we operate on this hip, or should we just let the patient kind of be medically managed with bed rest, et cetera. And the evidence is really clear that surgical management is superior. However, you do have to take patient consideration into account, and we'll talk about that in just a minute when we talk about the concept of clinical momentum. There's a current large trial called the Hip Attack trial, which is looking at kind of time to operative intervention. As I'm sure you all encounter, sometimes orthopedic surgeons consider hip fractures to be emergencies, and they need to go to the operating room right away. The data doesn't support that yet, and there's still a little bit room to go there. I'm not going to belabor this too long, but in terms of regional anesthesia versus general anesthesia, there's really no clear evidence as to which is better yet. There's a question as to kind of the effect on delirium and postoperative cognitive dysfunction. I will say that one of the reasons that this probably hasn't borne out in terms of having better results in terms of morbidity and mortality with regional versus general is the fact that once patients get a neuraxial approach for their anesthetic, they usually then on top of that get a general anesthetic with a natural airway. So in terms of management of that kind of patient and trying to look at whether they have less postoperative cognitive dysfunction, we're kind of shooting ourselves in the foot in that assessment. So let's talk about clinical momentum, and I think this is really, really important when you look at these patients that are presenting, especially those patients who present who are incredibly frail coming into the hospital. It's a system-level, latent, previously unrecognized property of clinical care that may contribute to the provision of unwanted care in the ICU. What do I mean by this? So your 80-year-old grandma presents to the emergency room after a fall from standing. She has a hip fracture, she has a subdural, she has some broken ribs. You decide that the best course of treatment, despite the fact that she has expressed that she would never want to be mechanically ventilated or have supplemental nutrition or anything like that, is to send her to the ICU because that's where she'll have the best chance of recovering. However, she goes to the ICU and that night she requires some vasopressors. Then she has a central line placed. During central line placement, she gets a pneumothorax. Then she has to have a chest tube placed. And you go down this line of things where one intervention leads to another intervention, leads to another intervention, where you could have just intervened at the beginning and decided, Grandma is very, very, very frail coming into the trauma bay. The likelihood of her having a positive outcome and recovering to her functional status, even as limited as it was, is really small. So how do we want to proceed forward, and do we want to involve palliative care teams earlier on in the kind of diagnosis and management? And I think kind of using that frailty assessment within your initial assessment kind of as you go through and assess these patients is so, so important to then kind of preventing this occurrence. So parting thoughts. So there's been a shift of the demographics. Trauma is no longer just a disease of the young. It's certainly a disease of the old as well. You always have to remember kind of just the normal physiologic changes of geriatric patients and the fact that there is a loss of functional reserve as a result of those, that standard protocols for triage just aren't good enough for these patients, that you need to make some modifications to improve and impact your morbidity and mortality when you're assessing these patients. Management continues to be a work in progress, and if anything has been demonstrated, it's the fact that a multidisciplinary team is the best approach for these patients, and that an early discussion of goals of care is so, so important to prevent kind of the concept of clinical momentum. With that, I will take any questions, and I thank you for this opportunity.
Any questions for Dr. Joyce? I have a quick one for you. When you say that we should be sweating in the operating room when we take care of a geriatric patient, how warm do you warm your rooms?
So 85 degrees.
85, okay.
Degrees. Yeah.
That is warm. All right. We're going to open up the floor now for any questions that you might have. We have about 10 minutes left. And if anyone has any questions, please approach the microphones in the middle here, state your name and where you're from. And while people are gearing up to do that, I have a question for the panelists, and that is, how specialized should we become as departments of anesthesia? I know when we presented to the House of Delegates for the American Society of Anesthesiologists, we said that every department should have a trauma anesthesiologist, and then he or she would bring back the department information on how to manage trauma patients. David, you work in a pediatric hospital, so that's fairly straightforward. You have all your patients are cared for by pediatric anesthesiologists. But do you have a view, Dr. Viejo or Dr. Joyce, on how, especially with geriatrics, is it so specialized that we should have someone in each department with that expertise?
At least what happened in my institution, I'm at West Virginia University, and it just seems like we're going more towards like the groups or columns of like institutes. And we have we just separated into a heart and vascular institute. We're going to separate into a children's institute, and it's almost then a neurology institute where everything is like children's, for example, they can provide a better line of care. And not only is it just that you have people just focusing on pediatrics, it just shows there's plenty of studies out there to show if that's what you do it really good, you provide a better line of care, and it's also better for negotiating insurance things, those type of things. And also, if you move over to like neurology, so they were like, well, okay, we can do neurology, we could do behavioral medicine, we could do neurosurgery. So by having those institutes, it seems like they're more competitive in the marketplace with better care.
I think within the kind of geriatric trauma realm, most of these patients aren't presenting necessarily directly from the emergency room. So it's generally a kind of a delayed presentation. The majority of these patients that we encounter are patients that come up with hip fractures, or we're going to the intensive care units to provide epidural placement for rib fractures, et cetera. So in terms of whether we should have a geriatric anesthesia trauma specialists, in an ideal world, yes. However, I think as long as kind of from a baseline anesthesia, if in essence, based on the patient populations, and clearly at a children's hospital it's a little different, the bulk of patient populations that you're caring for on a daily basis kind of fall within that age 65 plus range. And thus everyone, in my opinion, should have kind of some expertise per se in geriatric anesthesia.
First microphone, please.
Good day, John Stacey from Australia. Across these disparate groups, I just wanted to ask the panel what they think the role of point of care thromboelastography, whether ROTEM or TEG is, and whether there are any outcome benefits in its use in major trauma across this range of groups.
Was the question about pre-hospital care?
No,
or?
point of care ROTEM or TEG, so thromboelastography.
Oh, okay. Oh, I see.
I can tell you what I love it. I think it's great to have it. We typically, if you have a patient that's like 80,000 or so, a platelet count, you would like, well, we're going to do a spinal and epidural neuroaxial anesthesia. So if there's a question and it seems to be okay, I'll get a TEG. And if the TEG is good and positive and it's normal, then I'll go feel much better, go ahead and do a neuroaxial anesthetic. So I love it. I think it's great, and it really can help dictate care. The other opposite is not only getting an epidural, but how about taking one out? So you have someone has postpartum hemorrhage or some issues or whatever, and they want to go home, but you're afraid to take out the epidural, and then you get a TEG, and if it's normal, you feel much better taking it out. So yeah, I think it's great.
David?
I guess I would say definitely can be useful, probably particularly in the resuscitation of which blood product to give as an example. The problem would be turnaround time. And that's something that we've had challenges in our institution where the turnaround, where you're making management decisions probably quicker than you can get the results back. So I would say if that issue can get compressed, then absolutely. I mean, the technology is very helpful. I think it's just the implementation.
We also are working on turnaround time at our institution. I think for geriatric specific patients, it's incredibly helpful given kind of the degree of diastolic dysfunction that patients present in and kind of the care that you want to have and allowing you to kind of be more goal directed in your resuscitation. So 1 to 1 to 1 may not be the most ideal ratio for that patient that's presenting with a degree of volume overload to start already.
Second microphone.
Brent McNew, Johnson City, Tennessee. Thoughts on the use of TXA in some of these special populations, like pre-hospital in a pregnant woman, given she's also hypercoagulable, or in the geriatric patient, they've got heart stents, and they're on antiplatelet or other blood thinners. Should they be getting TXA in the operating room for these in that situation? So.
Yes, that's on the list, and it's really good to give. So if you have someone postpartum hemorrhage and you're having a hard time and you can't stop it, you should definitely consider TXA. It's a most definite good way to go.
Do you recommend it pre-hospital or pre-op?
Well, I guess you could, but like in ortho, you do that a lot. And I know when I do ortho, we'll go ahead and do it intra-op or right before the surgery or whenever they want us to give it. But no, I would suggest just after if you do have hemorrhage in the last, ditch effort, you've gone through you've gone through Pitocin, you've gone through Methergin, you've gone through prostaglandin F2 alpha, and that's not working, then you should try, as a fourth line, do TXA.
David and Frankie, do you guys use it?
We do. We do not use it routinely. I think it's more of a default if we're seeing problems that, particularly though, like I said, like the last question, I'd much rather know the results of the TEG to be able to guide therapy than probably thinking that TXA is going to be very beneficial. That's the other issue, is how beneficial is it going to be? Are we concerned about giving it? Not necessarily.
In full disclosure, I'm not a fan of TXA, kind of empiric TXA for all patient populations. I think most of the study and literature looks at very unique populations that aren't necessarily the 65 plus populations that are presenting with multiple comorbidities, et cetera. I think the kind of bandwagon of TXA is probably going to be stopped short at some point once we have more goal-directed kind of thromboelastography, et cetera, that will help us to kind of better determine and be more patient-specific in our treatment.
Brian McGrath, UF Jacksonville. So I have a question that's somewhat related to that issue of specialization. So, and mainly directed at David. So we are a trauma center for northeastern Florida, and we have a pediatric hospital in Jacksonville that receives the majority of the pediatric trauma, but not all of it. So we are not a pediatric hospital. We do a smattering of healthy kids, and we have this small number of major pediatric traumas that come to us. And I believe we have one pediatric trained person on our staff. So my question is, what advice might you have in terms of training for individuals who will care for a pediatric trauma patient on a very sporadic basis?
Yeah, that's a big challenge because, as you know, it's not just the anesthesia provider, it's the system. And, it's all the components that really need to be integrated, just like what Manny was saying regarding on the institutes. That's a big challenge. I mean, just training the anesthesia people is not going to help when you're trying to get x-ray, when you're going to, try to get pharmacy to make it, dose dependent and so on. So I would say that's a big challenge. I don't have a particular great suggestion other than knowledge, sure, of ATLS and so on would be helpful for that single provider, but that's still not going to help bring up the entire environment.
Manny?
I have two conflicting thoughts. One of them, when I was a junior attending, it was amazing because I pretty much just do obstetric anesthesia. But when I was a junior, during the day, I never got to do like neurosurgery cases. So that it was just amazing. I never did. But then I'm on call at night and like suddenly I'm a specialist. So there's always that gray zone. It was like, oh, okay, I finally get to do neurosurgery, but it's just amazing how they do that. So it's sort of different in the sense that, a lot of hospitals aren't all or none, and we tend to think of it. My second thought, a conflicting thought, is that with all these ERAS protocols going through, so hopefully if you have something built in for the pediatric patient, for the neurosurgical, for the geriatric patient, that might be one avenue that could help in going forward.
All right. That concludes the session. I appreciate your attendance and your participation, and I want to particularly thank the three panelists.